Good morning. Welcome to CME lecture series conducted by Candy Society of Medicine. As you know that every week on Wednesday, we are having this CME lecture series organized by our society. And as I usually inform you, this is a hybrid. That means in addition to the live lecture here, most of our members, even students and the other doctors, are joining the lecture through the link provided by us. So, because of the current situation of the COVID, we started this new link that to facilitate majority to listen to the lectures at the same time, the imaging the movements as well as the more bigger audience here. Now today our lecturer is I think Heshan is a professor now. I think Professor Heshan Jayaweera, the consultant pediatrician and the professor in pediatrics, Department of Pediatrics, Faculty of Medicine, Peradeniya, and Heshan is a graduate, and he's known to everyone of us and start having a lot of introduction. And he's going to talk on the very common topics in the headaches in children. I think that will be benefited to all the doctors who do the private practice, postgraduates to improve their knowledge as well as update the knowledge of this general area of interest to all of us. And I have some announcement. I will do this at the end of the lecture related to the Candy Society of Medicine. So I'm welcoming Professor Heshan Jayaweera to do his lecture. Heshan.
Dr. Dukshant Mendagariga, President of the Candy Society of Medicine. Ladies and gentlemen, sir, thank you very much for the kind words of introduction. And as you have already said, I will be talking about headaches in children. As you all know, and as you are quite aware, headaches in children is a fairly common thing. And over the next 45 minutes or so, I will try to take you through with an overview of headaches in children. We will try to classify disease. We'll discuss briefly about clinical assessment, investigations, and then we will talk in detail about some of the common entities that lead to headaches in children. So I will be talking about tension headache and migraine. And then, of course, the latter part of the lecture, I will be talking to you about secondary causes of headache, which we need to know, which are, again, not uncommon. So talking about headaches, it's a fairly common complaint in the pediatric population. And if you look at studies done worldwide, it is thought that about nearly 80% of children would have experienced an episode of headache by the age of 15 years. And if you look at the world literature, it goes to show that over the last decade, number of patients coming with headache seeking advice has increased. And actually, world literature tells us that there has been about a threefold increase of patients seeking treatment for headaches. And the etiology of this, of course, could be multifactorial. So as you are quite aware, all age groups are affected. So it is not something that is common to only adolescents, or it's not something that we only see in the preschool age group or in the school-going age group. Even small children do suffer from headaches. And not only that, it leads to a lot of anxiety in the parents. It leads to loss of school and also impaired school performance. And those of you who practice medicine, who see patients on a general practice basis, will agree with me that there are a lot of patients who come and seek treatment mainly because the parents are worried that their child might be having some sort of a major problem because of the headache. So if you look at the pediatric neurology referrals, it actually accounts to about nearly 50%. So what about the situation in Sri Lanka? No different. We don't have very many studies. This is a study done in 2016, done in Polonnaruwa, where they have studied or looked at students between 11 to 16 years. About nearly 700 students have been followed up, and they have found nearly about 30% of them having headaches. And they have described primary and secondary headaches, which I will go into in a short while. And in this study population, the prevalence of migraine has been about 7.8%, and nearly 50% of them having migraine without an aura. So what are the challenges that we face when we are encountered with a child with headache? As you would agree with me, toddlers, small children, they have problems of communication. Their way of communication is either by crying, or they will become very clingy, irritable, and so on. And very often, as pediatricians, one of the main concerns we have is we are not sure what is going on, right? Similarly, they might vomit, they might become irritable, rub their eyes, and so on. So there is a huge challenge about how patients present. On the other hand, there are certain pathologies which are not uncommon, which can present with headaches. And into that, we have space occupying lesions, seizure disorders, emotional problems in children, psychological problems like depression. They also sometimes present with headache. So therefore, all this goes to show you that a very careful evaluation of children who present with headaches is a mandatory thing. And what is good about things is that very often, if we take on a comprehensive history examination, most of the time we will be able to come up with a diagnosis and treat these patients so that they become better. So moving on to the second part, we will be now trying to classify headaches so that it is easier for us to deal with these patients. So there are two broad classifications that have been brought about. One is, of course, by the International Headache Society, and this is based on the clinical picture, and there are set diagnostic criteria. On the other hand, there is another classification which classifies headaches on periodicity and the pattern of presentation. So these are the two standard classifications that are currently in practice. So if we talk about the International Headache Society classification, which is slightly different to the one that I've shown you here, where they go into the two arms, the International Headache Society classification gets headaches divided into two further categories, where you have primary headaches, which are headaches with no detectable cause that is present. So the common entities there are migraine, tension headache, and cluster headaches. And then, of course, you have the secondary headache disorders, where there is an identifiable cause. So it could be related to an infection. All of you know that patients with CNS infection, those who have infection of their sinuses, can sometimes present with headache. They can have headache because of pain getting referred from head and neck structures. It might be carious teeth, it might be blocked sinuses, and so on and so forth. There could be intracranial disorders, which could be either non-vascular or vascular. So things like rarely AV malformations, sometimes space-occupying lesions, cerebral abscesses, and so on. In children, food additives, drugs, more so the stimulant drugs, which are gradually becoming available in some of the schools. These are emerging things in our society. Psychiatric disorders and trauma are also considered into the secondary headache disorders. So if we go to the other classification, which is based on periodicity, then of course you can classify headaches into isolated acute, acute recurrent, chronic progressive, chronic non-progressive, and of course mixed headache. So what do these mean? So an isolated acute headache is defined as a recent onset headache with no prior history or similar episodes. So this is probably a very common presentation where a child might have an upper respiratory tract infection and end up having a headache. And it may also be the presenting symptom of a variety of intracranial pathologies. For instance, a patient who comes with a headache and has ongoing fever, we may have to consider whether this child could be having either meningitis or encephalitis. You go to the acute recurrent variety, here there are episodes of headache with symptom-free intervals. Moving on further, the chronic progressive headaches. Here, the headache frequency and severity is getting worse over time. So if a patient comes and tells you that I've had a headache and the headache is getting worse, it is becoming more frequent, then this is very worrying. So of this periodicity, the chronic progressive headaches are the ones that are quite dangerous, which we need to sort of deal with very quickly and try to fix a diagnosis. The chronic non-progressive disease, headaches, of course, they differ from the acute recurrent type by their greater frequency and the persistence, and they have been there maybe for a number of years. So things like migraine will get categorized into the chronic non-progressive type. So talking about assessment of headache, key to the diagnosis is usually to identify those who have secondary headaches, because if we don't identify the secondary headaches, we will have an issue. And as you all know, I've said this previously, children are not very good in giving histories, neither are they good at telling us what exactly is going on. So if you actually tell the patient, can you draw and show me what you are experiencing, and they may be able to put it down graphically. So these are some of the drawings that children have drawn to sort of express what their headache is like. If you look at this one, you see that this child is showing as if there are knives being pierced on the head. Here again, you see the child is showing that there is a big load on the head. There is someone whom the child is carrying. And this is probably to say that the headache is episodic, it gets slightly better, and then again there is a burst. So on and so forth. If you tell your patient to draw and show you, or if you have a smiley face at say 10, and you have a very, very sad looking face, which is 0, and if you ask them, how significantly do you feel during the time of headache? And then an older child might be able to tell you whereabout it is. And that again will give you some idea as to how much this child is suffering from the headache. So moving on, I think now we need to find out how we are going to assess these patients who come with headache. So what are the things that we need to ask? Obviously, this is no different to any other history taking. But of course, there are certain things that we need to lay emphasis on. So finding out what has happened, how the headache began, how long it has been there is important, because then you will be able to recognize whether it is isolated acute one, or whether it is chronic and progressive, or whether it is chronic and non-progressive. There could be exacerbating and relieving factors, which we very often see. Sometimes patients have got treatment, and when treatment doesn't work, they have visited several practitioners, and treatment may have been escalated, and finding out what has been given, what investigations have been done is again important. Then finding out the circumstances that bring about headache. For some children, it may be that the work or changes in circumstances in day-to-day life, maybe in school, maybe changes in family dynamics, and so on, can bring about headache. So trying to find out such things will be useful because it will give you some idea whether any of these could have caused or would have contributed to the headache. We ask about warnings because patients who have migraine sometimes can have an aura, so that becomes a warning. Sometimes children, when they are stressed out and so on, and they would roughly know that they are about to develop a headache and so on and so forth. Where the headache is, whether it's a generalized headache or whether it is localized, if so, which part of the head is it localized? The nature of the headache is again important. The other associated symptoms, what are they? Common things are that they could have nausea, some of them can have vomiting, some others can have abdominal pain, whether there could be maybe things like blocked nose, sneezing and so on, because sometimes some of the secondary causes of headache are common and we try to fix them to a primary cause and you fail because you have not picked up the secondary causes of headache. It's important to find out how it affects a child because children, they're smart. So when they want attention also, one of the things that they would say is that I've had a headache because obviously parents get worried. Sometimes they say they have tummy pain, and that's another common symptom that they say. So if there is an headache which is really worrying, and the child complains, and within about 2 minutes he's okay and he's running around, and then possibly there could be nothing seriously going on. And finding out whether there has been effect to schoolwork, whether there have been any changes in behavior and so on is important. What makes it worse? What makes it get better? Whether medication makes it better, circumstances like maybe looking at a TV or breaking rest, so on and so forth, whether they make it worse is another important thing. Presence of comorbid problems, like children who come with a headache to you could have other illnesses. Some of them might be being treated for maybe a respiratory illness, long-standing. Some of them can have illness in relation to other systems. So finding out whether they are taking medication for other illness is important because sometimes the headache might be related to the other illness that is being treated. History of head injury is very straightforward. Family members with headache go on to say that this could be a familial disorder like migraine, which is common. Disturbed family dynamics, another key important thing, which patients will not volunteer unless asked. Unfortunately, there is a fair number of children who suffer because of disturbed family dynamics. They can have issues at home because there is conflict between parents. Sometimes there is conflict between peers. And not only at home, they can have conflicts at school. Conflicts at school could be with peers or it could be with the teaching staff. And as a result of it, sometimes the child might develop a headache and he or she will not probably want to go to school or have issues at home. Asking about features that suggest raised intracranial pressure, progressive neurological disease is important, and the loss of school or inability to go to school or not attending school can be used as a proxy to identify how severe the problem is, more so in patients who are going to school or going into nursery. So if they are missing school, then either, which goes to say that there is a serious problem at hand. Use of drugs and chemicals, drugs in the sense not the substance abuse, but sometimes children are children, as I say. Sometimes they might start taking, or they prefer to take medications that are used by adults, and as a result of that, they can get headache. We also need to consider the possibility of childhood sexual abuse. So it is in both males and females both. Headache and abdominal pain are one of the key presentations where children can present with sexual abuse. So what are the symptoms that suggest a secondary headache? So if there is a very short history and a very severe headache, which has been going on for a few weeks, if the course is very accelerated, so it is getting worse and the patient is really distressed, the timing and the posture, so if you have early morning headaches, or you wake up with headache, or you have associated vomiting, nausea at the time you wake up, those are significant things to think about secondary headaches. So what are the associated things that would make you worried? As I said, if the patient is vomiting, if there is associated confusion, alteration in personality, focal neurological signs, recent onset seizures, plus or minus low-grade fever for which the child may have had treatment, then again, these are important things to pick up. So let's move on to examination. What do we examine? So the focus of examination will be determined by the history that you take and the clinical context that you are thinking about. If you are thinking about that this patient could be having a headache because of sinusitis, then you will probably need to look at the upper respiratory tract to see whether there is evidence of nasal turbinate hypertrophy, sinus tenderness, and so on and so forth. So it's helpful to identify such children and then examine them properly. You have to look for signs of infective etiology depending on where the infection you would be suspecting. So if you are thinking of a meningitis, you will have to look for features, clinical examination features suggestive of meningitis. Signs of raised intracranial pressure, like maybe looking at the pupils, checking blood pressure, Koenig sign, Rutsky sign, that kind of thing needs to be done. And mind you, if it is a small child, undertaking all these things is not going to be easy. So if you are checking blood pressure and the child is irritated, and you might get an isolated high reading. So you may have to repeat the blood pressure reading when the child is in a more settled environment. So while you examine, you need to lay special emphasis on examination of the ears. Look at the eyes to see whether there is any kind of refractive error, possibly sometimes. So you may have to do a very gross visual assessment. Look at the sinuses, look to see whether there are dental caries, because sometimes children come with very bad teeth and they have referred pain giving rise to headaches. Tender scalp arteries, evidence of other systemic illnesses, not common, but certainly look for it. Patients who have got cyanotic heart diseases, it's well known that they can develop cerebral abscesses. Those who have features of chronic renal failure, they can come with headache because they are hypertensive, and whether there are other associated focal neurological signs. So what investigations do we do? Diagnostic investigations are only necessary when you have a secondary cause of headache. Otherwise, now, as I said, in the primary headache disorders like tension headache and migraine, there are no diagnostic investigations. They are basically diagnosed on history and normal examination. Routine lab investigations are again unnecessary unless you are thinking that there could be a secondary headache. Say you are suspecting that a patient has got headache because of meningitis, you may order a blood count, CRP, which will show you a neutrophil leukocytosis and elevated CRP. you might undertake a lumbar puncture in that case, or you think could be something going on. What about neuroimaging? Is it possible? Is it always necessary? Unless there is a real indication, I don't think we should undertake neuroimaging, because one thing is that getting neuroimaging is quite difficult, and we should be able to use our clinical judgment and then decide which patients will need neuroimaging. So if there are signs and symptoms of elevated intracranial pressure, focal neurological signs, progressive new signs appearing in a patient, recent significant head trauma, patient is significantly distressed with headache, there is associated BP shunt, then they may be the ones whom you may have to undertake doing a CT or an MRI. So goes to show you that a careful history and a detailed clinical examination would be able to sort out most headaches without further investigations. And if you can make a confident diagnosis, then I think you treat the diagnosis that you have made and then see whether your patient will respond. So it's not a case of treating and letting the patient off. You may have to bring the patient back to your clinic or to your practice to see how the patient has felt, whether he has improved or not. If he has not improved, then of course we may have to rethink the diagnosis. Otherwise, if he has improved, then you could always, reaffirm yourself that your clinical diagnosis has been right. And it will also give confidence to your patients to say that your diagnosis, or you have been a doctor who has made a decent diagnosis. Right. So now let us talk about the primary headache disorders. And here, as I said previously, diagnosis is entirely on history. There is very little that we can pick up on physical examination. So I'm not going to list out all the entities. I have listed out tension headache and migraine and cluster headaches. I will talk a little bit about the first two entities because they are quite common. So what are tension headaches? These are very common in pediatric age group. They are little difficult to differentiate from migraine, and we see them building up in children, maybe of school age, more so in children who are about to sit scholarship exam, maybe when they are faced with a public exam or when they are close to their end of term exams. So the headache is quite often apparent during school days, and it is likely to build up in intensity as the day progresses because the child is getting more and more work, more and more stress into his life. The headache is generally described that it's distributed in the frontal region, but sometimes the headache can get localized in the vertex or the occipital region. In a tension headache, you would generally not have nausea and vomiting, and it is not influenced by physical activity. So diagnosis is made by exclusion at the completion of physical examination and history. Right? Most of them, children who have tension headaches, will have some insight as to why they develop these headaches. It might be that they have poor self-image about themselves. It might be at home or it might be in school. They fear failure at school. Failure at school is not that they are not doing well. They compete with each other in the class. Teachers also expect students to perform equally. So therefore, there is worry about whether can I be like so and so? Can I get similar marks? So as a result of that, they worry whether they will be looked down by either sometimes by the parents themselves, because there are parents who say, why can't you be like the other one? Look at him, he's different. What they don't realize is that children are unique. Everyone can't be the same. Sometimes they lack self-confidence, and that can also lead to tension headaches. And rarely, if this continues for a long period of time, they can end up with childhood depression. So how do we treat them? It's important to reassure and explain to them why they might be experiencing the headache. We need to talk with them about coping strategies. Children sometimes may not be able to cope by themselves. So therefore, getting the parents to support children during these times, maybe helping out with schoolwork, getting the child to go out and enjoy life, maybe go and play for maybe half an hour, watch TV and so on and so forth. They're important because they are children. Otherwise, what happens is that most of the time, when they come home from work after school, they are inundated with homework and they work till late night to try and finish it because they are worried that they might be harassed the next day if they haven't done so. So it is thought that the stress might cause isometric contractions of these muscle groups that I have described, and that could lead to this characteristic dull, aching headache. If a patient is not getting better and the parents are worried, and you still think that this could be a tension headache, a brief period of hospitalization will be useful because you are taking the child from the so-called normal environment to somewhere else where you would be able to observe, you would be able to see how difficult it is for the child when he or she develops the headache. So that is something that we can do for extreme cases. So let's talk a little about migraine. So this is again an important type of recurrent headache. We look at prevalence, it's about 10% in children between 5 to 15 years, and it increases to nearly 25-30% in adolescents. There have been small differences that have been shown geographically, but it is well known that girls are likely to develop migraine as opposed to boys. And about 10% of men and about 15 to 20% of women rather, have migraine. So in 2004, the International Classification of Headache Disorders came into place, and they described several migraine variants. So there is migraine without aura, which is also called common migraine, which we commonly see in pediatric practice. There is migraine with an aura. Then there are other variants called childhood periodic syndromes, retinal migraine, and so on, which are not very common. So what are the criteria to diagnose common migraine? So there are several criteria that have been laid down. So you may not be able to think about migraine at the first presentation because if you look at these criteria, this goes to say that there has to be at least 5 attacks fulfilling criteria B to D. So what is criteria B? Is headache is there, which can last from about 1 hour to about nearly 3 days. In C criteria, we have if you have two other following, like whether if the headache is bilateral or unilateral, the quality of headache, more so if it is pulsatile, moderate to severe in intensity, which gets aggravated by routine physical activity, and if there is associated nausea, vomiting, photophobia, phonophobia, then you would be able to make a confident diagnosis of headache. So you don't need to wait until the patient has had 5 episodes. Maybe by the second, third episode, you would be considering whether this child is fulfilling criteria to have a so-called common migraine. So the criteria for migraine with aura is slightly different. In addition to the criteria that I mentioned in the previous slide, they could have aura, and the aura are fully reversible symptoms. The aura can develop over a few minutes, and you can have 2 or more symptoms occurring in succession. Aura is unlikely to go on beyond 1 hour, and soon after the aura, your headache will continue. So, migraine without aura is the common entity, and as I said previously, you might not make a diagnosis with the first or the second episode. The duration again is about 1 to 72 hours, and the period of sleep that the child has after the episode has started is taken into the duration, right? And about nearly 90% of patients who have migraine will have a first or second degree relative who has recurrent headache. Sorry. Right. So I have tried to show you some things. They all just jumped out without, without any control. These are sometimes what patients come and explain, or this is sometimes what patients see. So this is what is an aura. It's a neurological warning, which is about nearly 5 minutes, and it can consist of visual symptoms. It can consist of sensory symptoms, and there can be speech disturbance. So photopsia is something that is very well described, where patients during an aura can have flashing of lights. They can come and tell you this. Sometimes they can have what are called scotomas, where you might lose out the central vision and you might see only round it. And then the headache will come on. And sometimes you can have something like that, where your peripheral vision is lost, but your central vision is there. So if you go on internet, there are several of such images that have been uploaded, which you can see. And sometimes some of you may have even experienced some of these symptoms. So what is hemiplegic migraine? It's again not a very common entity, but I will just touch on it. It's considered a migraine aura, and it is characterized by unilateral sensory or motor signs during an episode of migraine. So patients who get headache can present with numbness, which involves the face, arm, and leg. There could be unilateral weakness, sometimes aphasia, and these neurological signs are fairly transient. And there is also an entity called familial hemiplegic migraine. So what are the goals of treatment for migraine? We need to reduce the headache frequency, we need to reduce the severity, and also try to minimize the disability that occurs with this. We should try not to have a reliance on acute treatment unless there is a real need. We should try to improve the quality of life in the patient and also try to avoid acute escalation of medication in trying to control the headache. So education to enhance personal control of migraine is another goal in treatment. So how do we manage an acute attack? I'm sure most of you are aware of this because I'm sure many of you will be treating patients with migraine. So the analgesics that are considered or recommended is paracetamol, ibuprofen. Sometimes you can use sumatriptan. If the patient has ongoing stated migrainosis, which is headache lasting for more than 3 days, then of course there is recommendation of IV prochlorperazine, but we don't see that happening very, very frequently. We think about prophylaxis when the headaches are frequent, when they are disabling, and the patient is affected and with a lot of distress. Generally, it is given for about 4 to 6 months, and if the patient is asymptomatic, and then we can tail off medication. The commonly used drugs are flunarizine, propranolol, Pizotifen, and valproate. And very often, other than the medication that we use, behavioral management is also very effective. So when you use propranolol, be careful. If the patient is an asthmatic, then it may be contraindicated. But flunarizine, propranolol, and Pizotifen, they work very well in children. So what is the behavioral modification? We need to tell them to try and avoid things which are known to cause or precipitate migraine. It may be chocolates, it may be nuts, coffee, cheese, sometimes other substances which can bring about migraine, right? So commonly, what we see now is that most of the uh, you know stuff that is available on the market, which children love to eat, contain salt, oil, and added preservatives like MSG. And MSG is well known to cause migraine. We tell them to try and avoid stress and fatigue, uh, avoiding direct light exposure to sun, loud noises, avoiding hunger, breaking rest. All these are known to be helpful in reducing migraine. Not in all patients. So if you find out that your patient gets an episode of migraine because of one of these things, then you tell him or her that they need to try and avoid them. Right. So up to now, what we have spoken about is that we have divided the headache disorders to primary and secondary. And in primary headache disorders, I've gone on to say that it is mainly diagnosed on history. Your physical examination will be normal, and we don't generally undertake secondary investigations. And in primary headache disorders, I have discussed with you two entities, tension headaches and migraine. And then, of course, we went on to the secondary headache disorders, which now I will go into, right? So let's talk a little bit about secondary headache disorders, where there is definitely a identifiable cause that is present. So why do we get headaches due to infection? Commonly in children, meningitis, encephalitis, brain abscesses are known to cause headaches. Sometimes systemic viral infections, for instance, dengue, and gastrointestinal infections like maybe typhoid, bacillary dysentery, and so on, because of a toxic encephalopathy, can bring about headache. And think about abscesses, because very often, uh, patients sometimes get treated unnecessarily with broad spectrum antibiotics. And sometimes we see patients who have been missed, and they're probably missed with CNS infections, and then probably partially treated coming in with cerebral abscesses. If you are thinking about patients who have got cyanotic heart disease coming with headache, I think seriously you need to wonder whether they could be having a subclinical brain abscess. Referred pain from eye and head and neck structures, refractive errors, myopia, when you can't see the board, they can present with headaches, sinusitis, mastoiditis, acute otitis media, chronic suppurative otitis media, problems, dental caries, apical abscesses can give rise to headache. Then another common entity is neck muscle spasm. More so because these days, you see, you look at children, they're not schooling, they are with devices, and they are glued to devices to get through their work. So concentrating and looking at something very close by can give rise to neck muscle spasm, which can bring about headache. Non-vascular intracranial disorders, benign intracranial hypertension, not common. We see it on and off, mostly because we have a program where we give vitamin A megadose because there is possibility of vitamin A deficiency in the community. Elevated intracranial pressure may happen because of space occupying lesions, sometimes hydrocephalus, for which a shunt has been inserted, but the shunt may get blocked, and other toxic substances. So those are some of the images just to highlight that neoplasms are one of the things that you need to consider if a patient presents to you with a headache. And then, of course, even hydrocephalus, where patient might be just coming in with irritability. And if you have taken the trouble to measure the OFC, you might realize that there is a rise in the occipitofrontal circumference. Vascular disorders like AV malformations, subarachnoid hemorrhage, which might be either accidental or non-accidental, can give rise to headache. Intracranial hemorrhage, cranial vasculitis, and connective tissue disorders like SLE has to be considered in children who are maybe adolescents, and of course things like cerebral venous thrombosis. We may also have to keep in our mind that hypertension could be presenting as headache, and sometimes it is patients who have got acute nephritis, and they might just come to you and say, I've got hypertension or I've got a headache, and you check the blood pressure and you realize that the pressure is elevated. You may rarely come across patients who have pheochromocytomas and hypothyroidism coming and talking to you about headache. Not very common. Food additives and drugs, mostly because our eating styles have changed. There is histamine-rich food, which is known to cause headaches. Sauces, substances that contain a lot of MSG. And then, of course, drugs like steroids, if they are used long-term. Methylphenidate, which is used in patients who have attention deficit hyperactivity. They are also known to cause headache. Then, not forgetting the other disorders like psychiatric problems where children can have anxiety and they can progress to childhood depression, and their presentation too might be headaches. Think about trauma in small children. Don't forget it. I'm sure all of us would probably, that would be one of the first questions you would ask, because trauma may have been witnessed sometimes. Sometimes if the child is being looked after by someone else, it may have been witnessed, but it may not have been communicated to the parents. So I think with that, I will stop. I have tried to take you through to give you a bird's eye view of how to approach a child with headache. And I think I probably given you reasonable amount of information where you will be able to have a structured approach to a child who presents with headache. Thank you for your attention.
Heshan, I think thank you very much for giving the comprehensive update about the headache in children, pediatric age group, and I will discuss most of the thing I think what we should know. Now, before we conclude in the lecture, I'd like to give the person a few announcement that all of you know that our annual academic congress session will be on 7th to 9th of April. Now we received a substantial number of abstracts from here as well as the other places, and now we are waiting for these orations. So the Bible Memorial and as well as the KSM oration is the closing date to the 15th of this month. So that's why people may be preparing. So just hand over the on no before 15th of this month. Number one. Number two is that so all can join to this lecture through our link, and they can even watch later. So we are going to upload this all the presentation to our YouTube, Facebook, with the permission of all the speakers. Think that others can be enjoy this lecture by listening to them even later when they have time. I think actually the importance of that the other activities conducted by this our society, we are going to a tree planting program in Kandy, municipal area, on 16th of this month. So I'm inviting all of you to join that. We already organized and arranged everything. Tree planting program in the city of Kandy. We are helping the environment to have a safe environment and the proper environment to have the good health of all of us, not only the humans as well as the animals. That is one of our concepts we are doing this year. So the other things are 2 books are available, written by our consultant, one by the Professor Ratnatunga, as well as another book by Dr. Deepa Gunawardena. It is available in the KSM office. You can by that time just to help this and the Professor Ratnatunga's book, all the money was going to give for that to represent the PEMSA. I think that's very important to me. So just to help that, so just to remind again that. And so once again, I must thank the Dr. Heshan Jayaweera, Professor Heshan Jayaweera, having a nice, good lecture with the information what is necessary. On behalf of the Society of Medicine and all of you, and thanking very much coming from Peradeniya and helping us to conduct these CMA activities. Traditionally, I to hand over the certificate of appreciation to Professor Heshan Jayaweera. Thank you very much.